Bonnie's another guy who never gives up. It's great.
Very, very true.
Yeah.
All right. Well, I think we're ready to start. And good morning, and thank you for joining us for the Winship Grand Rounds this morning. I'm Kimberly Huang, and if you are an Emory University or healthcare employee who would like to receive CME credit hour for attending today, then the login information can be found in the chat feature at the bottom of your screen. If you have any issues with this webinar or the CME login, please send Kadiatu Fufana an email or drop a note via the chat feature. This morning, we are pleased to welcome Dr. Anant Mandawat. Dr. Mandawat graduated with a medical degree with honors from the Yale School of Medicine in New Haven, Connecticut. He completed his internal medicine residency at Massachusetts General Hospital, Harvard Medical School in Boston, Massachusetts. He then completed his fellowship in cardiology at Duke University Medical Center in Durham, North Carolina, where he focused on cardio-oncology and advanced cardiovascular imaging. Dr. Mandawat serves as the Director of Cardio-Oncology at Winship Cancer Institute of Emory University, and holds joint appointments as Assistant Professor in the Department of Hematology and Medical Oncology, and in the Division of Cardiology of the Department of Internal Medicine at Emory University School of Medicine. Dr. Mandawat is an expert in the early detection, prevention, and treatment of cardiac diseases in patients with cancer. He specializes in cutting-edge techniques to detect cardiac disease early and prevent complications that may result before, during, and after cancer treatment. He has a clinical interest in long-term cardiac risk assessment and follow-up in cancer survivors. He has received advanced training with a specialized fellowship in cardiovascular imaging. Dr. Mandawat is a board-certified internal medicine and cardiovascular disease and has additional board certifications in echocardiography, nuclear cardiology, as a registered physician in vascular interpretation. He holds professional membership in the American College of Cardiology and the ACC's Cardio-Oncology section. Welcome, Dr. Mandawat.
Thanks so much, Kim, and thank you everyone for joining this morning on this talk on cardio-oncology, a path towards bigger and bolder cancer care. Here's my disclosures. So we have some research support from Pfizer, Myovant, and the Prostate Cancer Foundation. I thought I'd start with a case. Mrs. R, she's a 40-year-old female. She's a patient of mine. She's an administrative assistant. She has a past medical history of hypertension, hyperlipidemia, and she's diagnosed with stage 3B triple-negative left-sided breast cancer. She's scheduled to receive neoadjuvant therapy with dose-dense adriamycin and Cytoxan plus Taxol. In the setting of receiving anthracyclines, a baseline echo was ordered, and here's what that looks like. So let me orient you here. So this is the left ventricle. This is the mitral valve. This is the left atrium. This is the right atrium. This is the tricuspid valve, and this is the right ventricle. Here you can see normal left ventricular ejection fraction with a trivial pericardial effusion. These are the 3D views of her heart. So this is with a single echo probe. We can actually cut the heart in multiple different views. And then we trace the end systolic and end diastolic volumes to generate what's called our ejection fraction, which is here is 57%. So again, normal to start off with. This is her strain imaging, and we'll talk more about strain imaging later, but you can think of it like an early warning system that helps detect cardiotoxicity. Here, her strain number on the bottom here is negative 19%, which is normal. And again, we'll talk more about this later, but starting off, you know that everything looks good in Mrs. R. In interval, after her third cycle of AC, she presented with shortness of breath and lower extremity edema. And in that setting, a repeat echo was ordered. And here's what that looked like. So again, let me orient you here. So this is the left ventricle. This is the mitral valve. This is the left atrium. This is the right atrium, tricuspid valve, right ventricle. Here you can see that our left ventricular function is moderately reduced. You can also see that our left atrium is dilated with bowing out of our interatrial septum from the left to the right, suggesting elevated left atrial pressures as well. Here are new 3D echo volumes. So again, tracing the end systolic and diastolic volumes, we generate an ejection fraction of about 41%, down from 57 to start. Here's a new strain imaging plot. So you can see here that her global longitudinal strain is now reduced from -19% down to -9%. So all consistent with her clinical picture of heart failure. So here's a question that we often get. You're consulted regarding the management of Mrs. R's heart failure. In particular, her oncologist wants to know how best to proceed with her cancer therapy while protecting her heart. And here's some choices. Stop her AC, she shouldn't receive it again. Dose reduce additional cycles of her AC. Add cardioprotective medicines and consider restarting her on AC. Or recommend she be referred to palliative care. So I'll let you think about this for just a second. So there's no easy answer here, right? I mean, you're stuck between a rock and a hard place, and that's classically the patients that we see in cardio-oncology, right? On one side, you have the cancer, where you certainly don't want to leave that untreated. And on the other side, you have her heart disease. That's a complication potentially of her treatment. And the more you push, the more that could get worse. And so it's this balance, this tightrope that you're going to see time and time again throughout this talk. And you're going to see how we approach it in some of the following slides. So the objectives for today, first, is to talk about the rise of cardio-oncology, in particular, this connection between cardiac disease and cancer. We're going to understand a clinical framework on how to approach cardio-oncology. It seems like there's new oncology drugs and therapies coming out almost every week. So it's going to be impossible to run through all of them. But really what I want to do is give you a framework on how to integrate cardiovascular disease and cancer so that regardless of any drug that you see that has complications to the heart, we have a system of how to work through it. We're going to apply that system to anthracyclines and then also talk about strain imaging, how it works and what it means. The last part of the talk is just future directions and special populations, talking some about immunotherapy and the complications there, as well as some of the research that we're doing in prostate cancer. So the way I designed this talk is cardio-oncology really is a new field, and I think it challenges a lot of the paradigms that we've learned about cardiac care in cancer patients, particularly time from our training, either in medical school or postgraduate training. And so what I did was I'm going to present these paradigms to you, and then I'm going to present evidence to refute it and hopefully try to convince you that we're really entering a new era or new frontier of cardiac care in cancer patients. So let me start off with this first statement. This is something I actually overheard in the emergency room. Cancer patients are not going to do well anyway. We don't need to worry about their heart health. So let's talk about that one. Let's look at that by the epidemiology of cancer and cardiac disease. So these are the top 10 causes of death in the US. This is an awards list you don't want to be on, but consistently heart disease and cancer are #1 and #2 in both males and females in the US. The other reason I like this chart is it shows you how much heart disease and cancer dominate over the number 3 through 10 causes of death. So regardless of who you are, an oncologist, a cardiologist, a general practitioner, invariably you're going to see patients that live at the intersection of heart disease and cancer. This is a chart of innovative compounds in phase 1 through 3 development over 2 decades from the 1990s to the 2010s. It's broken down by specialty, and really one line stands out here, and that's on oncologic drugs. And there's been a rapid growth in new oncology therapies that are available. That's led to improvements in survivals in many cancers. I mean, this is data from SEER from the 1970s to the 2010s showing improvements in breast, lung, prostate, colon, and bladder, and there's many more. That's also led to an increased number of cancer survivors. In the 1970s, there were about 4 million, 2016, over 15 million, and 2040 expected to be over 26 million. So by any metric you use, we're doing better and better in taking care of cancer patients. And really the question becomes, how do we push that needle even further? And how do we do even better for these patients? And one way to look at that is to look at the top non-cancer causes of death in cancer patients. And here's that data. This is again from SEER from the 1970s to the 2010s. And really what stands out to you here is the area in red, and this is cardiovascular disease. I think the other important point that in this slide is that really we traditionally thought of cardiovascular disease as something that affects patients maybe 5 years down the road, 10 years down the road. But you can see here, this is something that really has an impact on patients as soon as they're diagnosed and then all the way through their journey. Ultimately, what are we trying to do in cardio-oncology? We're really trying to shift this curve. So this is data from over 36,000 cancer survivors from Kaiser Permanente linked to SEER. You have follow-up on the x-axis and survival on the y-axis. What it's showing you is the line in red, cancer survivors with cardiovascular disease really have the worst survival out of any group. And what we're trying to do in cardio-oncology is really move them up this curve, move them up from the red line up to the gray line, and therefore have a big impact on their outcomes. So going back to this statement, cancer patients are not going to do well anyway. We don't need to worry about their heart health. Hopefully I showed you that this is a myth. Due to innovations in cancer therapy, survival from cancer has improved. Cardiovascular disease is a leading cause of morbidity and mortality in cancer patients. And the prevention and treatment of cardiovascular disease improves outcomes in cancer patients. So let's switch gears and talk about a framework on how to approach cardio-oncology. Here's another statement. So cardiac issues in cancer patients is a down the road kind of problem. Let's get them through their cancer treatment and we can worry about the heart later. So to tackle that, let's talk about this concept of a competing therapeutic dynamic between cancer and cardiovascular disease. So what do I mean by that? So in cancer, when we're treating cancer, the goal is really to target, starve or destroy malignant cells. We do everything possible to be able to do this, right? Cytotoxic therapy, targeted therapy, immunotherapy, anything we can do to go after that cancer cell is really the goal. In contrast, in heart disease, when you think about it, the goal is to really heal, nourish, and protect cardiac myocytes. For instance, when someone comes in with a STEMI, the first thing we do is we try to take them up to the cath lab and open up that blood vessel so we can increase blood flow to the heart and help it heal and recover. So let's take that and apply it, for instance, to VEGF inhibitors like you see in this figure. So with VEGF inhibitors, they inhibit angiogenesis and essentially cut off blood supply to the tumor. But as you can imagine, anything that affects blood vessels is going to have deleterious effects on the heart. And that's what we see. We see cardiotoxicity with these types of drugs. And so it's this yin and yang that you're going to see time and time again throughout this talk. And it's a core concept in cardio-oncology that these drugs, you have to really find that right balance between when do you put your foot on the gas so you can treat the cancer, when do you back off so that we don't cause too much damage, particularly to vital organs like the heart. Ultimately, if that yin and yang doesn't balance out, you can develop cardiotoxicity. And what does that look like? Well, this poster child for that is really anthracyclines, and you can see that here, and we're very familiar with that, and we'll talk more about that as far as heart failure and what that means. But one of the reasons I like this figure, it really shows you that the spectrum of toxicity can be quite broad, from hypertension, coronary disease, valvular disease, pericardial disease, arrhythmias. Really, the whole spectrum of cardiology is what you see from some of these drugs. I think the other thing that's a point to note is that the damage can both be acute or chronic. I mean, we know about anthracyclines traditionally associated with chronic damage, but things like 5-FU can be associated with coronary vasospasm, radiation can be valvular disease many years later, arrhythmias can be quite acute. So again, this idea that there's both sides of the coin here when we're dealing with some of these drugs. I think the last thing that's really important to emphasize is we have a lot of interventions in cardiology, and it's really a matter of trying to understand and be very thoughtful as to which ones could help our patients here, particularly in this population. Everything we do has implications for the patient. If we put a stent, if we put a device, if we treat a valve. And so it's very important to have a thoughtful approach in tackling all these different things, and particularly a team-based approach. Ultimately, if a patient develops cardiotoxicity, what are the implications for the patient? So it can be devastating, right? And we've seen this. There can be interruption or discontinuation of their cancer therapy, and we know that that's associated with worse outcomes. There's the physical morbidity and mortality of cardiovascular disease. There's the psychological impact of an additional severe comorbidity. And we don't talk about this enough, I feel. It's really, you think about it for these patients, they get a cancer diagnosis, then they're told you have to take all these toxic therapies that may not make you feel good, nausea, vomiting, etc. And then in the middle of that, they get this gut punch of saying, well, actually, your heart's in trouble, it's been damaged, and we have to stop your cancer therapy, so we don't know what to do, how that's going to work out. So we spend a lot of time in clinic, first time when the patients come in, and talking to them and saying, hey, it's okay, we've seen this before, we've gotten other patients through it, we'll get you through it as well. This audience knows particularly well that clinical trials are really a last lifeline for patients, but unfortunately, cardiovascular disease can frequently be a disqualification for these clinical trials. So it's really important to be proactive both in the prevention of cardiovascular disease, but also if it happens, to be able to rapidly assess and treat it so that they can continue on their trial. So back to this statement, cardiac issues in cancer patients is a down the road kind of problem. Let's get them through their cancer treatment and we can worry about the heart later. Hopefully I showed you this is a myth. There's a competing therapeutic dynamic between cancer and cardiovascular disease, placing the heart at risk. Many cancer therapeutics are associated with acute cardiac damage, and the implications of cardiac toxicity includes interruption or discontinuation of cancer treatment and worse patient outcomes. So what's the promise of cardio-oncology? So if we know that cancer therapeutics are associated with cardiovascular complications, and we also know now that cardiovascular disease can be a rate-limiting step that excludes patients from optimal treatment in clinical trials, then really collaboration between cardiologists and oncologists can result in bigger and bolder treatment options and improved overall outcomes for patients. You can see from this figure, really, cardio-oncology has three goals, right? Maximize cancer treatment, minimize cardiovascular toxicity, and as a result, improve overall outcomes for the patient. So how do we take that kind of pie in the sky concept and apply it to the patients that we're seeing in clinic? So one way to do that is this integrated approach of cardiovascular disease and cancer. So what do I mean by that? So let's go through it. So after a cancer diagnosis, everyone has a baseline level of cardiovascular health called their cardiovascular reserve. For each patient, that's 100% the best cardiovascular health they can be. When they're receiving their cancer therapy, invariably, they're going to have some level of cardiovascular insult, and that may drop their reserve down from 100% down to 75%. They don't have any structural heart disease at this point, but they may have what's called subclinical toxicity. Ultimately, if that continues, they can develop structural heart disease with a decline in their ejection fraction. And if that persists even further, they can develop clinical symptoms and ultimately the morbidity and mortality associated with heart failure. So where are areas that we can intervene for these patients? So certainly we can see these patients before they start their treatment to optimize their cardiovascular reserve, things like risk factors, comorbidities. Once we know the drug or therapy they're going to receive, we can develop a monitoring plan for them, both for the provider, the practitioner, as well as for the patient, who's often concerned about these things. If we detect any subclinical toxicity, we can intervene early in the form of cardioprotective medicines. And then certainly if they're having a drop in ejection fraction or they develop symptoms, we should be seeing these patients. One of the key points here is the earlier we see these patients, the better chance we have for myocardial recovery and the better chance we have to preserve this cardiovascular reserve. I'd say 10 years ago, really, the field was focusing on this area of intervention, kind of after the damage had already occurred. And over the last 5 years, we're really focusing on before and during therapy, again, with the idea being the better we can preserve that cardiovascular reserve, the better we can work hand in hand with oncologists to really deliver bigger and bolder care. So let's take that paradigm and apply it to anthracyclines. So here's another statement. Anthracyclines don't cause damage unless they're over a certain threshold. I've actually seen this time and time again in cardiology board review books. So let's tackle that one. So anthracyclines, let's talk about that. They were discovered from the fungi Streptomyces. They function by inhibition of topoisomerase 1 and 2 that's involved in DNA replication and repair. They're used in clinical oncology starting in the 1960s. And as this audience knows, they're effective in treating a wide variety of cancers, so much so that they're on the World Health Organization's list of essential medicines. Now, we've known about cardiotoxicity from anthracyclines for a long time. This is the first case series that was done in 1970s. 399 patients at Baylor and MD Anderson treated with adriamycin. They found 11 cases of adriamycin-induced cardiotoxicity, including this chest X-ray from a 24-year-old with osteogenic sarcoma. On the left is her baseline chest X-ray. On the right, you can see she's in overt heart failure. They found only one case of toxicity when the dose was less than 550 milligrams per meter squared, and therefore recommended in the 1970s that be the limit, the 550 limit. Now, echo wasn't widely available in the 1970s, and that 550 cutoff was largely based on clinical symptoms. So understanding that, Swain and colleagues in 2003 studied the rate of heart failure using echoes in 630 patients with breast and lung cancer who received doxorubicin. And what they found was that doxorubicin-related heart failure occurred at a lower dose, now 400, and with greater frequency than previously thought of from the 1970s. So now we dropped the dose from 550 cutoffs to 400. But could it be that the threshold for cardiotoxicity was even lower? It's just that we didn't follow up these patients long enough. So Mulrooney and colleagues looked at that in 14,000 survivors of childhood cancer. And what they found was that with longer follow-up, the threshold for cardiotoxicity was even lower now at 250 milligrams per meter squared. And this really solidified a theme for anthracyclines that cumulative dose, even at small doses, can cause cardiac damage. So let's put that all together. This is the latest figure from the ASCO educational book. Here you have cumulative anthracycline dose on the x-axis and odds ratio of cardiomyopathy on the y-axis. And what you can see here is after that 250 cutoff for Mulrooney, really the odds ratio increases dramatically, right? 7, 23, 27. But what's even more fascinating is this end of the curve where you see with a single dose of anthracyclines, you're increasing the risk of cardiomyopathy by 65%. So again, it goes back to this concept of yin and yang, that even at small doses, these drugs can be toxic. And it's really important to have this balance in order to know how to best give our patients the best chance. So if we know that these drugs can cause toxicity, are there patients who are increased risk for developing cardiotoxicity? So ASCO worked on that in 2018, and here are the patients they identified. So those patients who received high-dose anthracycline, so over 250 milligrams per meter squared of doxorubicin, high-dose radiotherapy with the heart in the treatment field, and this two-hit hypothesis, lower-dose anthracyclines with lower-dose radiotherapy, or lower-dose anthracyclines with trastuzumab sequentially, or lower dose anthracyclines or trastuzumab alone, and any of the following. So multiple cardiovascular risk factors, again, this idea of the cardiovascular reserve, older age, or compromised cardiovascular function, and importantly, this low borderline ejection fraction, right, 50-55, which particularly in cardiology, we often gloss over and say, oh, that's okay. But clearly, if you're starting off with a lower reserve, it's going to be a higher risk. So we have clinical tools based on the patient's history. Do we have any imaging tools we can use as well? So that's where myocardial strain imaging comes in. So what exactly is it? So strain imaging is possible because ultrasound waves from echocardiography form a unique interference pattern from each myocardial segment. You can think of it like an acoustic fingerprint that we form for each segment of the myocardium. These patterns or speckles or fingerprints, if you want to think about them, are tracked throughout the cardiac cycle, and each segment is analyzed for a change in size or deformation. The deformation values are averaged and generate what's called the global longitudinal strain, or you'll see it in the report as GLS. The higher the absolute number of GLS, the better the LV function. So in other words, for Mrs. R, if you remember -19, it's better than -9. What does that look like on the echo machine? So this is the machine is tracking the different myocardial segments here, as you can see, and then tracks it throughout the cardiac cycle. We do this in the apical 4 chamber here, you can see, but we repeat it in the apical 3 and the apical 2, and ultimately average those values. And this, on the report, you'll see this as a bullseye plot is what this is called. And here you see the computer averaging the values, and then ultimately it generates this number of -19. Again, this is Mrs. R's. So this is what you'll see as a strain output in the computer. Is there evidence that strain imaging can help our patients? So there certainly is. This is the SUCOR trial. It was published in JACC in 2021. And really the question that we're asking is strain-guided initiation of cardioprotective medications better than an EF-guided initiation? There was an international multi-center prospective randomized trial of 331 anthracycline-treated patients with a median follow-up of 1 year. In the strain arms, less patients had cardiotoxicity compared to the EF arm. And among those with cardiotoxicity, the strain arm had a higher EF follow-up. So again, evidence to suggest that strain imaging can help our patients. So let's go back to this statement. Anthracyclines don't cause damage unless they're over a certain threshold. Hopefully I showed you that this is a myth. Anthracyclines are a versatile chemotherapeutic agent effective against cancer. However, they're also an essential poison that increase the risk of cardiac damage, even at low doses. Risk factor modification in cancer patients is important in decreasing cardiovascular events. We talked about the cardiovascular reserve. And then detection and action on subclinical dysfunction using strain results in better outcomes for patients. And we talked about the SUCOR trial. Let's tackle another statement here. We can't do anything for cardiotoxicity. And this is something I hear from cardiology fellows all the time. So let's talk about this. So really the $1 million question here is anthracycline cardiotoxicity reversible or not? This is a schema that came out of MD Anderson by Uhr and Lipman in 2005, and they classified cardiotoxicity either as type 1 or type 2. Now, type 1 damage, the characteristic agent was considered doxorubicin, and they said the underlying damage appears to be permanent and irreversible. That sounds pretty definite. Type 2 damage was trastuzumab, which was felt to be largely reversible. Now, this schema has since become defunct, and let's try to understand why. So to do that, we really have to understand the timing of anthracycline damage, and there's really 3 phases. There's an acute phase that can happen over days. There's a subacute phase that can happen over months, and there's a chronic phase that can happen over years. And traditionally, that's where cardiologists saw these patients, right? They got anthracyclines many years ago, maybe 10, 15 years later, they present with some symptoms. Cardiologist gets an echo and says, uh-oh, the heart function's down. And oftentimes it's not a lot we can do to recover that. But the question is, when does the damage actually occur? And Cardinale and colleagues looked at that and found that 98% of the damage actually occurred within the first year after therapy. So what if we actually found the toxicity early and we treated it? Would it actually be reversible? And the answer is yes. So this is a study of patients who received anthracyclines and developed heart failure. And researchers examined the relationship between the time from anthracycline administration to the start of heart failure therapy. And what they found was that those who started on heart failure therapy within 6 months really had the best chance of improvement, and came to this concept of time to toxicity detection and time to toxicity treatment, similar to what you know about in STEMI, that door to balloon time is really key in helping these patients. Understanding that, the American Heart Association developed statements for monitoring on these patients, and this is one of the figures from there. And you see in the top row here for anthracyclines, they recommend a baseline echo for everyone, and that's essentially standard of care. Everyone gets that at this point. But post-therapy, they recommend assessment at the completion of therapy. And again, that magical 6-month cutoff based on the data I showed you. Again, if we find it, this is the best window where we could potentially treat it and recover function. Is there anything we can do to be ahead of the 8 ball? So this is dexaroxane. This is a Cochrane review of over 1,500 patients showing an odds ratio of 0.18 in the prevention of clinical heart failure. So certainly a drug that's out there, that the indications are somewhat more limited, but certainly that we've been able to use in patients that we consider high risk, and certainly get ahead of the 8 ball and try to prevent these things from happening in the first place. So going back to this statement, we can't do anything for cardiotoxicity. Hopefully I showed you that's a myth. Cardiac toxicity can be reversible. Anthracycline damage usually occurs within the first year of therapy. Time to toxicity detection is key, with earlier detection increasing the chance of recovery. And understanding the importance of early detection, the American Heart Association has developed screening guidelines for anthracycline toxicity. And dexaroxane is an effective tool to prevent anthracycline toxicity. Let's switch gears and talk about immunotherapy. Here's another statement. These new immunotherapy drugs are so difficult to pronounce, says all non-oncologists. This is actually the truth. Hopefully that got a little bit of a chuckle out of you. This is Jimmy Carter. He had metastatic melanoma to the liver and brain. He was treated at Winship with radiation and pembrolizumab. And in 2015, he announced he was cancer-free after an MRI didn't show any signs of his original disease. He did really well. He entered hospice care recently in 2023 at age 98. This is Hanjo and Allison, and in 2018, they won the Nobel Prize for their work in cancer immunotherapy. So what is it exactly? So it results in immunotherapy results in T cell activation. It works by targeting inhibitory immune checkpoints to restore the anti-tumor response. But however, these activated T cells can also damage cardiac myocytes. Again, this idea of a competing therapeutic dynamic. And one of the worst worries we have is when it causes myocarditis. Thankfully, myocarditis is not the most common adverse event for patients who receive immune checkpoint inhibitors, but unfortunately, when it occurs, the fatality rate can approach up to 40%. This is a case series out of the New England Journal showing how the natural history of immune checkpoint inhibitor myocarditis. What they showed is it's a rapidly progressive heart failure, malignant arrhythmia, shock, and death. And these are postmortem stainings, and you can see here that it stains positive for CD3 positive and CD8 positive T cells, and was negative for CD20. What tools do we have for the diagnosis of myocarditis? So really, we have our traditional tools, EKG, troponin, BNP, and ejection fraction. I think what's to note here is that if you look under ejection fraction, when these patients come in, they're short of breath, they have lower extremity edema. We often say, well, let's get an echo. And when we get an echo, we say, oh, the ejection fraction's okay. I don't think this is myocarditis. But what you can see here is that in over half the patients, the ejection fraction was actually normal or near normal at presentation. So it's really important in these patients, when you have a clinical suspicion for this, to continue to monitor them and keep a high suspicion. Ultimately, recognizing that we needed more data, we teamed up with Tom Nealon out of Mass General as part of an international cardio-oncology registry. And one of the questions we asked was, is strain imaging associated with major adverse cardiac events in ICI myocarditis? It was a retrospective case control of strain in ICI myocarditis versus ICI without myocarditis. And what we found was that reduced strain was associated with an increased risk of MACE in patients with both a reduced and a preserved EF. So another finding to suggest that strain imaging can be useful to help risk stratify these patients. And particularly if you have a normal strain, certainly gives you more kind of sleep better at night versus an abnormal. Perhaps we need to monitor these patients more closely. Another study we did out of the registry was looking at the relationship of steroid dose and timing to MACE. It was a retrospective study of 126 patients. And what we found was that higher dose steroids and an earlier time from admission to steroid initiation was associated with lower MACE. So again, this concept of time to toxicity detection and time to toxicity treatment is really key that you're going to see throughout a lot of these drugs. Thankfully, knowing that it has a high mortality, people have been working on different therapies we can use. And now we have more tools kind of in the tool belt, CD52 inhibitors and CTLA4 agonists that can really have dramatic results and melt down that myocarditis picture. So putting it all together, what does the treatment look like? So the first step, discontinue the immune checkpoint inhibitor, give high dose steroids early, and we talked about the data for that. You can add other immunomodulatory agents, CellCept, CTLA4 agonists. You can consider an endomyocardial biopsy. And then this is a key point, a slow taper of steroids once you have control of the disease with close surveillance. We've seen patients that have been referred from other centers. They've had control of the disease, but then they have tapered the steroids too quickly, and the disease can flare up, sometimes even worse than before. And so it's really important to take this slowly and monitor things as they go down. Going to the last part of the talk, just some future directions. Let's talk about prostate cancer and cardiovascular disease. Prostate cancer is the most common malignancy in men, accounting for 1 in 5 incident cancers. Among prostate cancer patients, cardiovascular disease, it turns out, is a leading cause of death, and it's largely felt to be from androgen deprivation therapy. Cardiovascular complications include higher rates of heart attacks, cardiomyopathy, stroke, arrhythmias. Let's review ADT quickly. So it's the mainstay treatment of prostate cancer in the US. Over 400,000 men receive it. The most common form is what's called gonadotropin releasing hormone agonists, or GnRH agonists, typically given every 3 to 6 months. There's ample evidence to show that ADT can help prostate cancer patients. It can be given for 3 to 36 months, but in metastatic disease, it can even be given lifelong. There's also a strong link between ADT and cardiovascular disease. It can lead to metabolic derangements. It can lead to cardiovascular events. This is largely epi data. So much so that it can increase the risk even as soon as 3 months after starting ADT. This led to a joint scientific advisory statement that was issued by the American Heart Association and the American Urologic Association, and that prompted the FDA to add cardiovascular event safety information to GnRH agonists. Now, putting all of that together, prostate cancer is common. It's often treated with ADT, and ADT is associated with increased cardiovascular events. However, we're also lacking tools for cardiovascular risk stratification, which are critical to improving outcomes in this population. So with that in mind, we created what's called a Cardio-Oncology Prostate Cancer BioBank, or CoPro. This is Sagar Patel in radiation oncology and Brian Olson in immunology. And really our mission here is to understand mechanisms and identify early biomarkers of cardiovascular toxicity in men with prostate cancer undergoing ADT therapy. The goal here is over 36 months, we'll be collecting 6 samples on these patients and really analyzing those samples for early markers of toxicity. One of our initial hypotheses is a lot of this is driven by the immune system. So it turns out that T cells have GnRH receptors on their surfaces, And when they're activated, they can cross endothelial cells, then the intima, and ultimately cause chronic inflammation that can lead to plaque instability, early rupture, and premature cardiovascular events. So our hypothesis is that elevated frequencies of T cell populations are associated with increased development of cardiotoxicity in patients receiving ADT and radiation therapy. Ultimately, our goal with the BioBank is really to provide a comprehensive phenotyping for markers that are associated with increased risk of cardiotoxicity following ADT. I showed you some of the immunomics experiments we're talking about. We're working on a genomic side, looking at CHIP mutations, of clonal hematopoiesis of indeterminate prognosis, and see if that can risk stratify patients. We have some really exciting proteomics experiments. We actually may be the first to show that a biochemical change in a cardiovascular risk profile that happens from 0 to 3 months for patients who receive ADT. There was epi data for this, but we have the first data to show that there's something happening as well from a biochemical side. So putting just the last slide here, kind of conclusions. There's a growing population of cancer patients, and improving the burden of cardiovascular disease is critical to improving their outcomes. There's a competing therapeutic dynamic between cancer treatment and cardiac health, highlighting the need for collaboration to deliver bigger and bolder cancer care. Cardiac toxicity, including anthracycline damage, can be reversible. Early detection and early treatment are key to reversing damage. Immune checkpoint inhibitor myocarditis is associated with a high mortality. Early treatment with high-dose steroids is indicated. And ADT in prostate cancer patients is associated with a high rate of cardiovascular events. Tools for cardiovascular risk stratification will be critical, hopefully some of them coming from the CoPro BioBank, to improve outcomes in prostate cancer. Thank you for your time. I think we have plenty of time here, hopefully for some questions if anyone has.
Thank you, Anant. If you do have questions from the audience, please use the Q&A feature located at the bottom of your screen. While we do wait on questions, I wanted to mention that next week there is no grand round scheduled due to spring break. And to view all of upcoming Winship Grand Round lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. Okay, we'll open it up for questions if there's anything in the Q&A or otherwise.
Toxicity related to TKIs, yeah. So the tyrosine kinase inhibitors, there's a variety of toxicities that we can see with them. We see everything from hypertension, we can see heart failure with them as well. Really an approach to understanding their mechanism is currently occurring. People have always focused on anthracyclines and focused on Herceptin. And so, I think there's certainly a pathway here to help understand how to prevent this and how to work better with it. We see these in a lot of the renal cell patients that we see. And one of the key points that hopefully I made across in all of this is a lot of what we do is a risk-benefit decision, right? So we see these patients and a lot of them come to us with concerns about some of the treatments and some of the things they've read. And one of the things that we emphasize to them is, compared to a lot of the other folks that they see, we're very familiar with these toxicities and we can help get them through these toxicities. And so that's one of the key messages that we tell folks, regardless of the drug we see, to say that, hey, we've seen this before, we can get you through it. And although it can be scary, and a lot of times a lot of other places don't know what to do with it, we can certainly get them through it. And certainly we try our very best to help not stop the drug, because we understand kind of this competing therapeutic dynamic and how important it is to continue on their cancer treatment as well. Yeah, interesting question. So Kristen's asking, I wonder if you could comment on whether T-cell directed agents such as Tacro could be used instead of protracted steroids to lessen the impact on cancer immunity after checkpoint inhibitors. So it's a really interesting concept. It hasn't been tested yet. I mean, I think one of the downsides in switching to a different agent after ICI myocarditis has been that the very high mortality that's associated with it, people are always nervous. We're even nervous at the point of decreasing down the steroid dose. I think as we get better control of ICI myocarditis, and particularly with this concept of treating it early and getting steroids on early, I certainly can see a scenario where we add up we bring on something like tacrolimus as we rapidly taper the steroids in maybe 2 arms and help see if that can be a better effect. But certainly an interesting point there. And in theory, from a mechanistic side, it should work. We do see a lot of tacro patients as well, because we see a lot of patients post bone marrow transplant, and we can see some of the side effects, primarily looking at risk factor profiles for cardiovascular disease, things like hypertension and hyperlipidemia that can occur from there. So certainly a drug that we're familiar with, and I think certainly has promise in being able to do that. I think people are, at least this stage in the game, a little too nervous from the mortality side for myocarditis, but certainly a good idea. Vitamin E, so Merv is asking about, is there any data about vitamin E preserving cardiac toxicity? The best area for vitamin E that in the literature is really after radiation. We've seen some data on that, that it could prevent radiation-induced cardiotoxicity. It's not it's certainly not a class 1 indication. People have been using it, and we haven't seen much downside to using it. We don't have a lot of tools. I didn't talk about radiation-induced cardiotoxicity today, but we don't have a lot of tools to fight against that. And so something like vitamin E, certainly, if there's a signal for benefit, I've seen folks use it. We don't prescribe it routinely. So I sometimes have patients come and ask me about it, and really what we talk about is there doesn't seem to be a big downside. We don't have definitive evidence that it helps, but certainly something that they can try. Body's asking, would you prefer echo or MUGA to assess baseline and monitor EF? So for MUGA's been a great tool to assess ejection fraction. The advantages of MUGA has always been that it's more reproducible. And so the idea that you can get one study after another certainly has value. And that was what was traditionally used. And I know it's used a lot in Grady as well. In general, the field has moved away from MUGA, and really the first line in pretty much all the guidelines now is echo. There's multiple reasons for that. I think first is echo is more widely available now. It's easier to do. Smaller centers could do it. It's easier for patients to get repeat measurements on those. The other major reason is obviously MUGA exposes you to radiation, and with the wide availability and quality of echo now, there seems to be a less reason to expose patients, particularly, for instance, breast cancer patients who may be young, to repeat radiation through the MUGA. So in general, I would say most of the field has moved away from MUGA. There's still instances where we use it. So, if there's a discrepancy in the echo, we don't believe it, or potentially if a patient needs to go on a clinical trial where we need a very exact measurement and echo is coming in borderline, sometimes we'll go to the MUGA test to be able to do that. So Ajay's asking, can you please discuss where we stand with biomarker-guided therapeutic decision-making akin to strain-guided decision-making? Yeah, Ajay, great question as well. So biomarker-guided decision-making is, there have been papers that looked at this, and they do suggest a role of biomarkers in being able to assess early cardiotoxicity. One of the trials that came out was a trial called SESI, and one of the endpoints was actually troponin to look at as an early marker of cardiotoxicity. Now, from a theoretical level and a physiologic level, this makes complete sense. The problem is twofold. One is when you use markers, and really the only validated ones we have are troponin and BNP. So BNP can be helpful. BNP, particularly when it starts rising early, is a marker that we often use, and we get a baseline and we get a follow-up, mainly because shortness of breath can vary in etiology. And so it's an important marker for us. So I would say that is certainly used more clinically. There's a lot of news and a lot of papers that are being done on troponin, understandably, because it's very specific to the heart. The downside on a practical view of looking at troponin, there have been some advocates of troponin after anthracycline administration and looking at it cycle to cycle to identify patients who are high risk. That if you get a positive troponin, particularly in the way our healthcare systems are designed, the subsequent triggers that it creates as far as workup and holding therapy, and some of these numbers can be very, very high depending on the doses that are used in anthracyclines. And so it really hasn't made its way on a practical level, just because the consequence of having positive troponins in our system is so large. And so I think in the right patient, potentially younger patients or patients that we're particularly worried about, maybe those who have a low EF to start with, and we want to make sure things are going okay, particularly if we have a potential of giving a high dose overall. Those may be good patients, but as far as routine use of them, certainly we haven't employed them. BNP may be the one exception. Do we do that? We do get that on a lot of patients, particularly at baseline. I see David Lawson has a question. We often see coronary artery calcification on CT scan. Is there anything beyond risk modification we should do? Is this a risk factor for cardiotoxicity? So David, yeah, also a great question. I get referrals for this as well for coronary artery calcification. So interesting, coronary artery calcification is similar in idea to strain imaging, right? Coronary artery calcification is a tool that came out more recently. It indicates a level of inflammation that's going on in the coronary arteries. It doesn't necessarily indicate that you have a blockage to that level, but it does indicate you have some level of inflammation, and that inflammation would put you at higher risk of having cardiac events. We don't have enough data to know if coronary artery calcification puts you at risk of developing specifically cardiotoxicity. When you're asking the question of what would you do for risk modification, I think for patients where you see coronary artery calcification, certainly I would put them in the bucket of patients who are higher risk of having cardiac events, certainly down the line. So we actually are working on a study looking at prostate cancer patients and looking at pre and post coronary artery calcification numbers in them to see that would that change, and particularly would it change because of ADT therapy. And so I think it's a marker, at least at this time, that's more relevant for patients down the line rather than, for instance, strain that's at least validated on a level of more peri-therapy or during the therapy being given, actually. Is there any preemptive treatment? So Merv is asking, is there any preemptive treatment or recommendation to preserve from cardiotoxicity for especially high patients? So yeah, you know, that really what we do for those patients, I think, is twofold. One is to understand the drug and how high risk is it and what it could potentially do to the patient. So for instance, VEGF inhibitors associated, for instance, with hypertension, cardiomyopathy, other drugs are associated with heart failure. So whatever those risk factors are, we can work on, or comorbidities, we certainly work on those. Again, getting to the idea of this cardiovascular reserve, knowing that these drugs are going to have this effect. So the higher they start as far as reserve, the better off they'll be during their whole journey. The one exception I talked about was dexaroxane. So dexaroxane, traditionally thought to be an iron chelator, but actually new evidence is coming out that it functions by interacting with, there's two isoforms of topoisomerase, so topoisomerase 2 alpha and 2 beta, and it appears that dexaroxane works against the beta form that's more present in quiescent cells, versus the alpha form is more present in rapidly dividing cells, like instance cancer. And so, you know, certainly that's a tool that I would argue is underutilized. A lot of that has to do historically with when it came out and the commentaries on it, and concerns with it as far as secondary malignancies or decreased therapeutic potential with the cancer therapy. But a lot of that has been debunked, but I think just it's kind of in the literature still, and so potentially underused for that reason. But I think as far as preemptive, that's the primary form, and then risk factor modification and comorbidity optimization. So Dong is asking, do those who have underlying coronary artery disease have higher chance of myocarditis by immunotherapy? So also a very cutting edge question here. So it turns out that new data is coming out that people who receive immunotherapy are actually at higher risk of accelerated atherosclerosis. We don't understand why. It's very new, but it's happening in mouse models. We're seeing it in epi data. And so a lot of this is potentially the unifying force here is inflammation. And so if it's driven by inflammation, it can affect your coronary arteries as well, which are small vessel arteries. And so more to come actually on that, but it's an exciting area of research. There was just an entire kind of journal section that was dedicated to that in the field about what to do about the mechanism behind this. The inflammation argument is a very interesting area as well, and something we're looking at that may unify, you know, ADT and some of the cardiovascular events we're seeing as well. And there's other trials that are out there, you know, Cantos that came out looking at inflammation. There's these CHIP mutations. So this kind of holy grail that could unify all of it. And I think people are chipping away at it. And I guess no pun intended from kind of this aspect as well, from immunotherapy and coronary artery disease. That's all the questions I see. Thanks again, everyone, for attending.